Being able to manage a colostomy efficiently makes an enormous difference to one's life. Colostomates who are able to irrigate feel far more confident, in control and positive about their stoma than they did prior to being taught this method of bowel management.
There are countless people who will tell you that their life has been changed by irrigating the colostomy, so that they don't have to worry about bags, about accidents at awkward moments in their social life.
In 1997, I had to have a permanent colostomy at the age of 46 due to bowel cancer. I was very fortunate that my surgeon was Professor Bill Heald and his Stoma Care Nurse was Sister Anne Lappington-Clark, to whom this DVD is dedicated. Prior to surgery, Professor Bill and Sister Anne had discussed my suitability as someone who could irrigate. The benefits of this method of bowel management are immeasurable. I've been able to be so confident, so in control of my stoma. I dictate to it when I want to irrigate. There's no set pattern, there's no set time that you have to do it. If you're going out in the evening, you can get it cracking before you disappear to do something wonderful. And it just gives you this incredible feeling of self-confidence. Since 2009, through our Tidings magazine, I have written a page on irrigation. The Colostomy Association knows that there are many colostomates who have never heard of this procedure, and we are encouraging them to seek advice from their stoma nurses and their surgeons to see if their stoma has been formed with a view to proceeding with this method of bowel management. We hope that this DVD will act as a reliable teaching tool and that stoma nurses will be encouraged to teach their patients and to give them an option of irrigation as a way of bowel management.
So who can be offered colostomy irrigation?
So some people living with a colostomy tell me that they've never been offered colostomy irrigation by their Stoma Care nurses. Why do you think this will be?
I think often it's difficult to judge when the best time to discuss irrigation. If it's a planned operation, ideally it'd be great to be talking to patients about irrigation preoperatively.
So how do I determine which of my patients would be suitable for irrigation?
Anyone with enough large bowel and an end colostomy is suitable for stoma irrigation. They have to have good dexterity and good eyesight because of the equipment they're going to be managing to irrigate with.
We have to remember that any patients with any renal or cardiac impairment, there's a risk of potential fluid overload, so we wouldn't recommend irrigation for those patients.
And also any patients that have active bowel disease, such as Crohn's, diverticular.
Let's have a look at the equipment.
Right, Emma, you're going to be teaching a patient to irrigate later on this afternoon.
Yeah.
So should we just go through the kit?
Yeah, it's been a while since I taught somebody, so refreshing ourselves with it would be really useful.
Yeah, me as well. Yeah. So I think let's just remember how we put it all together and just talk through the irrigation process, I suppose.
Perfect.
So this is the water container, obviously the Coloplast one, that we're going to use today, I think. Got to remember this comes in two pieces, but we've attached it already.
Okay, yeah.
So with the cone there. Absolutely. And the flow regulator for the water control. Yeah. So I think you need to remember positioning for the patient. What do you suggest usually?
Well, when I've done it in the past, we've always sat the patient on the toilet so that the sleeve that the patient wears is dangling into the toilet, but obviously I get some patients that are still finding it quite uncomfortable to sit for that sort of period of time on the toilet, so I don't know if there's any other way that you would suggest doing it.
Some patients do stand, don't they? As long as the bag is above the shoulder level.
Right.
So finding the best place for them to hang it for the gravity. Okay. And some patients sit next to the toilet, maybe on a stool or a comfortable chair, something a bit more comfortable with their cushion. Okay. And then they can put the sleeve into the toilet if it's long enough to go into the toilet.
Well, I didn't realise that, so that's
yeah,
really good.
I think realistically, it's going to be something that suits the patient.
Yeah.
It will change.
Yeah.
With the first teaching session, we probably either sit them on the stool or on the toilet
Yeah, okay.
and put the sleeve in. We start with, I don't know what you do, usually about 500 mils of water in the bag.
Yeah.
Just because when you then use the flow regulator, sometimes you're focusing on the patient putting the cone into the stoma,
and getting it right,
and you want to make sure that the water doesn't go in too quickly.
Yeah.
Because obviously, if that stimulates the vagus nerve,
we could have a collapsed patient.
Absolutely.
Yeah, or they could be feeling quite sicky.
Exactly, and obviously we'd just stop them, wouldn't we?
Yeah, absolutely.
I always feel when I always digitate the stoma first.
Yeah.
Feel which way the bowel is going.
Well, and also patients don't like to they're okay maybe inserting the cone, but to put their finger in might be a step too far.
Absolutely.
So I think then you know that you're at least going in the right direction of the bowel. So that's important.
Also, I think if there's a bit of hard stool there, they've not irrigated in the past. You can actually get that out of the way on that first occasion.
Okay.
Should we look at the actual sleeve itself?
Okay.
In this case, we're using the 2-piece.
Yeah.
And obviously, we'd need to connect it up, get the patient to take the bag off first, and clean around the stoma.
So I've not put this one together for a while because it's got the clip on it, hasn't it? So just clip it together.
Clip it together.
Oh, and then there's that. Because the last time I did this, I forgot to clip that, and it just all sort of fell apart when I put the belt on.
That's it, lovely.
Okay.
And then using the belt, obviously, to attach it to the patient.
Okay. So
I think somebody told me the other day you can actually trim this if needs be, if it's too long. So you can always advise that. I can imagine
patients, that's dangling in the toilet, and then I don't know about yourself, that we would then sort of clip that up with some pegs and it's retrieving it out of the toilet.
Absolutely. I think they flush the toilet anyway, so it's nice and clean, but I still think it's the idea of putting your hands in the loo sometimes, but they seem to manage quite well.
Yeah.
So, okay.
Yeah. Sounds good.
And obviously once they've irrigated and spent some time maybe waiting for the last bit of water to come out, they can then obviously take this off and replace it. Have a bag ready, always get them to have their appliance ready to use.
Do you give the patients a rough time frame of how long to leave this on for, or do you say, once you notice that it's slowing down, that's the time to put your stoma bag on? Or
I think we talk about maybe they get a cramping sensation, they might get some water back and then some stool, but it really depends, doesn't it, on each patient. And with the first irrigation, we know that things may not go to plan. They may not actually get much water back if they're a little bit dehydrated. And they may get the stool coming through, and then things settle down, and they should know.
I think it's just kind of having that sort of time frame in your mind, so that when you're talking to a patient and trying to instill some confidence, that they're not looking at us as though, well, you're not really sure. I'm not really sure.
Say 40 minutes to an hour, don't you?
Yeah. Okay.
And again, if they're not sure that the water's going in correctly, they can move around and reposition the cone, certainly in the first.
And often it leaks around the cone. Would you stop, reposition and go again, and that it, reassuring the patient that may happen quite a lot to begin with until we get it right?
But I still, for the first few times we teach them, I wouldn't put more than 500 in the bag.
Okay.
I'd still just use that for the time being.
Okay.
Until the patient feels comfortable to put more water in. Anything up to about 1,500.
Yeah.
But we don't recommend any more than that.
And they can do that in a couple of sessions. They don't need to do all that fluid in one go. No. They can sort of stop and start.
That's right, absolutely. Yeah. And going back to the actual water container, this has a temperature gauge, which is fine, but sometimes we just say the best way they can do it is to put their hand in and feel how warm the water is, and they'll know that as long as they can put their hand in comfortably, that water temperature should be fine.
Good.
The nurse talks to a patient about irrigation.
We've talked in the past about you trying some colostomy irrigation. Have you thought any more about that?
I've thought a bit about it, but I'd like a bit more information and maybe to look at some of the equipment needed.
Okay, just on the desk here, I've got the irrigation kit that we would use. Mm-hmm. It comes in a wash bag, okay, so it's discreet, nobody's going to know what's in here, okay, and it all folds away really nicely into this, okay. First of all, we've got the irrigation water bag, which is what's going to hold the water that's then going to be irrigated into your stoma. Okay, that looks like this. Now, it's got 2 litres in here. You're not going to be putting 2 litres of water into you. Okay. We would hang this in the bathroom sort of above your head, so because it's all done with gravity. Okay, so the bag has been filled with just slightly more than 500 mils of water, because we're going to prime the line, because you shouldn't put the cone into your stoma without there being water in this line, because we don't want to push air into your bowel. Okay. So what we're going to do is we put the cone over the. Do you want to hold it?
Okay.
So put the cone over the sink, and we've got this wheel here, and when we lift the regulator up and down, this will spin, and that will tell you how quickly the water's going to go into your bowel. The reason we ask you to do it reasonably slowly, your irrigation, is because it can stimulate the vagus nerve. Now, I'm not going to stand here and do an anatomy and physiology lesson, but it can make you feel quite lightheaded.
Okay.
So you just move this up, and hopefully the water should come out. And what we want is that it's about at 500 mils, which is this one here. That's it. Perfect. So the water's tepid, you know, just warm, not too cold.
The kit doesn't look too difficult to use, but how would it work in practice?
Well, Judy, who's been irrigating for a while, has agreed to do a short DVD of her irrigating, and the Colostomy Association has videoed that, so we'll take a look at that.
Okay.
Tell us, Sarah, what's happening here?
Well, Judy has all her kit to hand with her in the bathroom. The sleeve can be a 1-piece with a sticky flange, but today Judy's using a 2-piece with the belt, as discussed earlier. It's important to get a snug fit with the sleeve to avoid leaks. Warm a sticky flange just as you would with a stoma bag to help it adhere. Judy's going to sit on the loo, but the sleeve should be long enough if you prefer to sit on a stool or a chair next to it, whatever's more comfortable. Run the water out of the tube to avoid introducing bubbles into the colon. Some people may like to use a lubricant on the cone, but others find a splash of water over the stoma does the trick. The water temperature is important. Too cold and you may get stomach cramps. Too hot and you could damage the bowel. You'll find what works best for you, but a handy hint is that if it's a comfortable temperature for your hand, you're on the right track. Put the cone gently into the stoma in the direction shown to you by your stoma nurse and start the water flowing. It may need a little wiggle to get the angle right. You may find a little resistance if there's formed stool close to the stoma, so remove the cone to let this out. Relax and replace the cone. Let the rest of the water flow in, keeping an eye on the level of the water or the flow indicator to regulate the speed. It should be done slowly but doesn't take too long. The amount you use will have been discussed with your stoma nurse, but over time you'll get a feel for what works for you. Once the water is in, you can remove the cone and seal the top of the sleeve. Some have closures on, or you can use pegs. Now is the time to reach for your book, newspaper, or nip onto Facebook where you can relax and let the bowel do the work. Sometimes massaging your tummy can help things along. Some people see this as their me time, so relax and have some peace and quiet. Soon you will feel the bowel begin to move and waste will go down the sleeve into the loo. You may wish to flush the loo regularly to minimise the smell. Once the water and waste has been passed, you may wish to add more water. Many people use just one infusion, but others find they need a couple to ensure the whole colon is cleared. Then you can rinse the sleeve, perhaps using a jug of water, or let the water flow through the cone. You may wish to stay put and wait for the last returns, or some people like to peg up the sleeve so they can have a potter about. Here, Judy is making sure the sleeve is absolutely clean before rolling it and pegging it. Moving around may well help stimulate the bowel to remove the last of the waste and water. It's all about figuring out what works for you. We all have slightly different routines, which is developed over time. You'll learn to feel when you're empty. Then it's a case of removing the sleeve and popping it into a disposal bag. Don't forget, if you're using a belt, to hang on to this for next time. Dry off around the stoma well. Some people take this opportunity to have a shower, knowing that the bowel won't perform. Finish off by putting a fresh bag or cap over the stoma. Judy's using a plug here as she knows the colon is nice and empty. Then it's a case of cleaning the cone. I use some anti-bac wash and I leave the water bag and tube hanging to dry. It may get a little mouldy over time, so a monthly soak in sterilising solution can be a good idea. It's advised the kit be replaced every 3 months or so. And there we are, all done.
And now, Judy gives some encouragement for those who are thinking about irrigation.
I was really fortunate. I had a lovely stoma nurse who came to visit me here at home and told me about irrigation prior to my operation. So that was really good. That gave me something to look forward to in the future, post-operatively. All I would say to anybody that is going to irrigate for the first time, once you've learned how to do it, relax. Keep nice and still, nice and relaxed, good posture, and it will work for you. If it doesn't work the first time, don't give up. Persevere. If it doesn't work the next day, try again. It will give you a good life after a stoma.
So Helen, we've watched the DVD. How do you feel about irrigation now we've seen it?
I think now that I've seen somebody actually doing irrigation, I feel a lot more confident about trying it for myself.
Good.
And now the nurses discuss the suitability of irrigation for different patients.
So when we're offering irrigation to our patients, we want to really think of the contraindications. You know, why couldn't they irrigate, do you think?
Patients with large prolapse.
And, you know, carrying on from that, big, you know, hernias, peristomal hernias.
Yeah. But are you saying that with a small hernia it would be okay to consider
I think so,
irrigating?
yeah. And we'd, you know, like with anything we do, you know, it's a process of talking that through with the patient.
It's like anything as well. Every patient's different, aren't they? And everybody's different with their type of stoma and the problems that they have. I mean, some of them could have underlying inflammatory bowel disease or diverticular disease, and we wouldn't usually recommend that for patients to irrigate.
No, and then similarly they may have cardiac problems or renal impairment, which would be a contraindication. But if in doubt, ask their consultant. I'm never really quite sure when to broach the subject of irrigation with our patients. What do you think?
We offer it to the patients that are planned, that are going to have a permanent end colostomy. We offer it pre-operatively when we talk to them before their stoma formation. But I know that everybody does it differently.
I mean, the trouble is when you have a patient who's come into hospital as an emergency, has had no preparation of anything and ends up with an end colostomy. You know, it's really, I find in my practice, it's really difficult to broach when's the best time to say about irrigating, because they're coming to terms with having to deal with having a bag on their tummy.
Absolutely.
And even pre-operatively, they've got a lot of information's been given to them at that time, and irrigation is further down the line that they're not really wanting to take in.
And they might be coping with a diagnosis of cancer at the same time, so it's difficult.
Sometimes I think it's seen as a positive though, because it's something for them to hold on to, talking about control, bringing that back into their life and managing, rather than thinking, although they may wear a bag, they may be in control of when it functions. And I do think sometimes pre-operatively they do grasp hold of that. And we have patients who come to us at the 6-week point and say, when can I start irrigating?
But then when we see the patients, we're doing the daily teaching, that's a good opportunity. It's one-to-one, and while they're learning to manage the stoma and getting over how to manage their stoma care, we can introduce that, you know, this can be something that we can do later on, and we'll start it within 6 weeks, obviously depending on whatever further treatment you're going to have.
It's all about planting that seed that it's you've made the first step. You've kind of said, look, this is an option at the moment. You know, psychologically you're dealing with this, but we've got a few options down the line when you start to feel better, because we all know that patients post-operatively, you know, having a shower with a stoma bag on is a big deal, let alone putting a, you know, doing an irrigation.
But as stoma nurses, we understand that there's a huge psychological implication for having stoma formation, and you know, do you think that irrigation could maybe alleviate some of that?
I think with a lot of patients, when they have their surgery, there's definitely a loss of control in their lives. And I think teaching patients to irrigate gives that control back to those patients, lets them know that they're in control of their bodies again. And, you know, if we're discussing this, you know, pre-operatively, they can see that they're going to get their control back and they're going to get their lives. And I think, you know, we, as well as the Colostomy Association, we may get referrals. I've never seen a Stoma Care Nurse that have been out there for 30 plus years and go, well, I was discharged from hospital and was left to my own devices.
That's right.
So
they never thought that they needed a stoma nurse, or it was even a service that was available to them. And they kind of just got on with it, and it's only because they've had a problem and then gone to the GP, who then not sure how to deal with it, and then we'll refer on.
That's
and
right.
That's how we pick
but
up.
You know, what I would say to them
patients
is self-referral. They don't have to go to the GP. They can contact the hospital direct. And even if the stoma care nurse in the hospital doesn't see them, there will be usually a community stoma nurse that will see them if there isn't one. You know, if they don't go out and do community visits.
To teach them the irrigation.
Yeah, they can teach irrigation, absolutely.
In my experience, when we're discussing this with our patients, a lot of people are kind of, it's a fear of the unknown really, and they're just sort of taking a big leap into the unknown. So how do you really kind of overcome those concerns?
I think that once you've talked to them and you realise that actually they can try irrigation, and if it's not for them, it's a choice, isn't it? They can go back to either using a bag and trying it again at another time when they feel it's more appropriate for them.
I think patients can often find the equipment quite daunting, because there's a lot of pipe work and a bag they've got to fill. And I think it's just spending the time to go through that so that, you know, they can put it together and just have a practice without actually thinking the first time I set this up is the first time I'm going to irrigate. So often we'll
just have a play.
Have a play with it standing over a sink and filling it up. And
get used to the equipment.
Yeah, absolutely. I think that's really important. Yeah, definitely.
And once you get used, it's not really very difficult at all, is it? You know, once you put everything together and once they realise that, I think.
But it can feel as though you need you haven't got enough pairs of hands.
Absolutely.
And, you know, because
initially,
you've got to
exactly.
Yes. But I think it's like they say, practice, keep practicing.
Perfect. Absolutely.
Yeah, and it works.
And of course, you know, not to expect that the bowel is going to function perfectly well the first time you irrigate. It could take a while for things to settle, couldn't it?
I mean, you know, anything as quick as 10 days or up to 6 weeks, but every patient is individual.
Absolutely.
So therefore, how your bowel functions is completely different to somebody else. So how the control will come will be up to you. And it is a commitment to, with the practicing of doing it, to set a time, a regular time of day, each day to do it.
And would you start somebody off by doing it every day, or would you say let's try every 48 hours and see how it goes? How would you?
We'd often say, you know, to do it every day.
That's what we start. Yeah.
Just because actually, like we've said, the equipment's quite it's nerve-wracking going and doing it. Gives them that practice, and hopefully it stimulates that bowel.
And where would you want to do your first irrigation on the patient, or to teach them?
I think for me, we don't have clinical facilities, so for us it would have to be at home, but I think you would all say in an ideal world.
So we teach in clinic, and we have the time set aside to give them the time, because it is a long process, talking through, showing the equipment, and also getting them to handle the equipment.
I think sometimes it's down to the patient, you know, that whole thought process sometimes for patients of walking back into a hospital where they've had quite traumatic surgery sometimes can be really, you know, off-putting, and sometimes, you know, patients often say they feel like they're coming to sit their driving test, you know. So I think if some patients want to do it in their home, I think, you know, we have to be flexible, but we do have clinical facilities as well, so we just do it.
Be governed by what they feel at the time, you know. By then hopefully built up a rapport with your patient anyway, and know the way they feel about the irrigation, and it is a positive thing, isn't it?
Definitely.
Oh yes. Yeah.
How does irrigation change a patient's life?
I started irrigation, absolutely fantastic. Took all my fears away. You could have a bath or a shave or a shower without having to wear anything. And ever since that day, I've irrigated and been highly satisfied. Had loads of holidays, ski holidays, and everywhere. And I just absolutely don't know how to manage or cope with my life if I hadn't done irrigation.
I think it was the same for me. I was keen to start pretty much straight away. Started about 3 months after I got my stoma. But the difference mentally was huge. Yes, I could go to work, change the bag, and it wasn't a big deal, but it was always on my mind, you know. And to suddenly realise that actually 23 hours a day free, I could forget about it. And it really did change my life for the better.
I had a similar experience. I knew nothing about irrigation. I was never given any help by the hospital. And like you, I had to work in the daytime, maybe change the bag 2 or 3 times a day. When I started a support group, I met Doug, and Doug said to me, try irrigation, and it's been a complete change to the way I operate in the daytime. I don't have to worry about it, it's clean, and everything about it makes my life a lot better. I'd never want to go back. As much as I accepted I had to wear a bag, and I had to accept that because I hadn't had the help, but going on to irrigation really did change my life.
I always think if you're able to do it physically and you want to do it, give it a go, because I think you wouldn't regret it.
I think with me being a full-time student and studying and being quite young and active, I think irrigation has given me a much better quality of life to allow me to do these things without having to carry around 5 or 6 bags and having to worry about, you know, finding toilets when I'm out in public. It just gives me the freedom.
And you're in control of your bowel rather than the other way around.
Yes.
You can control. I irrigate to suit my day. If I'm going out for dinner, I'll do it before I go out. If I've got a big weekend, I'll do it on a Saturday morning and then Sunday night. So I make it work for me rather than me worrying the whole time about what my bowel wants to do.
I manage normally 48 hours between irrigations, and again I do it roughly the same time every 2 days, so it becomes a routine, but a routine that I can manage. If I do need to change it, I can, but it's no great deal. But 2 days is a good length of time to go to. Not everybody can do that, I know, but I've found that I can cope with 2 days, and it really suits me.
Yeah, I do it every day, which for me, I've got quite a fast transit time, but you know, to have 23 hours a day when I'm completely clear, it's well worth the time in the bathroom.
We've all got flexibility of our daily chores, haven't we, really? We can control it. Yeah, that's great.
You can even look at it as your bit of peace and quiet. I do when I sit in the bathroom,
Yes.
away from the kids, with a book.
Yeah.
Bit of
I
peace
listen
time.
to the radio and just Yeah, let it happen.
Helen takes a cup of tea, don't you?
I do. I take a cup of tea and I do my emails. But the biggest impact it's had on my life is it allows me to have a lot more freedom on holidays. I don't have to worry about changing bags in a foreign country and disposing of things, which I think is always a worry with all colostomates, you know, where to dispose of things.
In the morning, I do the TV and emails, and when I'm almost finished with irrigation, I'll often pop down to the local paper shop with my reader sleeves still on to get paper on my bike. Many times.